Okay, I think we will get going on this. Welcome everybody to Heart UK's webinar, Getting to Know Heartflow, which is extremely clever AI technology and to look inside your arteries. And I just hope that it will give some people a lot of comfort around knowing you don't have to have invasive interventions, or not everybody does. So it's a great innovation. So we're looking forward to sharing that information with you. This is being delivered in partnership between Heart UK and NHS England and Improvement and the HSS Network. So please remember you are on mute and your camera is not on. So you can put the kettle on and sit in the garden if you so wish. So that's great. Just to start with, housekeeping. This meeting is being recorded and it will be available on the Heart UK website. We will inform you if you've signed up to our e-news. We will let you know when that is live. Please feel free to ask questions, but please can you do so through the Q&A function on your screen. And we will aim to address all questions that we get today, but it will depend on how many we get. If we don't get to your question, then please rest assured we will actually address it and send out a Q&A mailing to attendees if we don't get to everything. And as I say, all the information will be on the Heart UK and also the Heartflow website, and we'll notify you of when that is. So just to go through the agenda, we're going to start with some welcome and introductions. We have a whole host of amazing speakers, and we'll start with Natalie Carter, who is the Patient and Public Involvement Manager at Innovation in the Innovation Research and Life Science Group at NHS England and NHS Improvement. Then myself, Jules Payne, I'll talk a little bit about Heart UK. Dr. Stuart Monk is the National Programme Director of the HSS Network, and he will talk about what they're actually doing. So the HSS are they're an agency, they're an arm of the NHS, and he's going to talk about what they're doing on Heartflow. Then Dr. Timothy Fairbairn, who's a consultant cardiologist at Liverpool Heart and Chest Hospital, will then talk us through how it works and who actually qualifies to get access to this really clever technology. And then we've got some patient experiences. So Claire Clues is who is a director of Lived Experience Network, and also Kevin Frisby, who is a patient and also Heart UK ambassador. And then Gina McDonald-Main will be talking about Heartflow. Why did she actually set the organisation up? And then we're going to listen to Lisa Beaumont around social listening findings. And this is very interesting for me because this is not something that I've ever done either. So this will be a great thing to listen to for myself as well. And then we'll close. But of course, that's not before we deal with your questions. So please do keep the questions coming. We've got some exciting presentations. So without further ado, let me move on to Natalie Carter to talk you through why we're here, basically. Natalie.
Thank you, Jules, and thank you everyone for giving up your time at 5 o'clock on a Monday to join us and learn about Heartflow. So Heartflow is one of the Medtech products. That's a medical technology product, and I will just give a brief overview to where Medtech products sit within the work that we do. So they sit within something called the Medtech funding mandate. So the Medtech funding mandate is a policy, and it's part of an NHS long-term plan commitment to get selected NICE, so that NICE is the National Institute for Health and Care Excellence, approved cost-saving devices, diagnostics and digital products to NHS patients more quickly. And I can share the link for the NICE guidance if you're interested in knowing which guidance document references Heartflow, but it's MTG32 for anyone who's really interested in nice guidance. So for something to qualify as a medtech product, it must already be approved by NICE. It must be cost saving, and within the policy document, that goes into more detail about how we evidence the cost saving element of a medtech product. So in the 2021-22 policy, for example, not only does it need to be considered as effective to be classed as a medtech product, but savings to the NHS have to be over 1 million over 5 years for the population of England, and the individual product needs to show that it saves costs within the first 12 months of implementation. So what are the actual policy benefits? So benefits for NHS patients, and that's our primary focus. This is about patients, this is about people. So it's about hospital avoidance. It's about reducing the length of stay for individuals. It's about closing the gap on inequalities by ensuring that proven innovative treatments will be available to everyone who's eligible. And by reducing the criteria to be a medtech product in 22-23, more products will be supported by the policy. So from 1st of April, we'll actually have 7 medtech products. So we had 4 in 21-22, and Heartflow is one of them, and we'll have 7 in 22-23. And what are the benefits for the system? So by that, I mean the health system, the NHS. So it helps the NHS recover from COVID. For example, because it's cost saving, it gets to the patients who needs it. It accelerates uptake of affordable technologies. So part of what this policy does is it speeds up access for people that need it. It's available on supply chain, removing the need for individual procurement contracts. So what that means is someone who, an NHS trust, for example, a clinical commissioning group, if you're trying to access this product, we have a national process in place that deals with the contracting to make it easier for an organisation to access this. And full implementation of the policy brings a saving of 25 million over 5 years. So that's for all the medtech products in 21-22. And as I mentioned in the previous slide, it's part of the NHS long-term plan. So it helps us to evidence that we are implementing the NHS long-term plan.
Fantastic. Thank you very much, Natalie. I think that set the scene quite nicely. I think for me, the most amazing thing is, the hospital avoidance and reduced length of stay from a patient perspective. That's a key, absolutely key. And it is great to see the investment. So next slide, please, David. Thank you. So as I said earlier, I'm Jules Payne. I'm the Chief Executive of Heart UK, the cholesterol charity. And Heart UK is all about prevention. We're all about preventing early disease and deaths from cholesterol and other blood fat conditions in the UK. And we'd like people to know and understand their cholesterol and other blood fat numbers and be taking appropriate action. This is really important. It's a simple statement, but it's really, really key for people to be able to really truly understand whether they're heading for a problem or not. You need to know your numbers. Next slide, please. So we provide education, support and influencing services underpinned by awareness raising. First and foremost is awareness raising, and we spend a lot of time and effort every year to raise awareness of the dangers of cholesterol and other blood fats. We provide a whole host of education and support materials. So education we are a hybrid charity. We provide our services for patients, for the public in terms of awareness raising who don't know that they're patients yet, and also for healthcare professionals treating people. This is this is an important service that we run. We are a national charity, so across the whole of the UK. We educate through sessions such as this. Patients, we put on an awful lot of activities around education. For healthcare professionals, we hold an annual scientific conference, and we have, for example, a primary care education program, because there's a very big need in primary care around raising education and knowledge of lipids through GP practices, pharmacists, etc. So we have a big program of education on both sides of the organisation. We also provide a lot of materials for people. This is free. These are all free for patients and healthcare professionals to access. So there's different leaflets, there's information on our website, which is extremely information rich, and there's lots of videos and webinars, and hopefully you'll be able to find exactly what you need on the website. But we also have a helpline, and that's known as a lifeline to a lot of people. So in terms of influence, I'd like to say that we influence people to do the right thing, to know and understand their number and take appropriate action. But we also influence policy. So this is government policy, and we influence for there to be a policy around keeping cardiovascular disease, and in particular cholesterol and other lipids, as a top health priority for the government. And that we're actually influencing how that is actually delivered through the NHS. We have a network of ambassadors across the UK, and they help us to really, they're our voice in the community, and they're really very important part of Heart UK to make sure that actually policy is getting implemented into practice locally. So this is very important. If you haven't already had a look at the website, please do so, and please know that there's all this information available to you for free. So I would now like to hand over to Dr. Stuart Monk, who will talk us through what the academic health science networks are actually doing around this Medtech product, Heartflow. Stuart.
Great, thank you very much, Jules. And yeah, one of the other things that we do in the HSN network is deliver a national lipids program. It's great to be working with Jules and the Heart UK team on that. So look, I've only got 5 minutes. I'll give you a very quick overview of the HSN network, talk to you about our role in delivering the Medtech funding mandate at quite a high level, but nonetheless should give you a bit of insight into the work that we do with Heartflow and the other technologies. Next slide, please. So our purpose, for those of you that haven't come across an academic health science network before, who are we and what do we do? There are 15 of us in England, that's the first thing to say. We've been around for almost 10 years. We receive most of our funding from NHS England and NHS Improvement. And our ambition and our purpose is to improve lives through health innovation. And we do that by taking innovations, particular service models, whether they're technologies, diagnostics, medicines, anything really that we know will meet that triple aim over on the right hand side. So improving the health of patients, driving economic growth and saving money in the health and care system. And we try and spread those innovations far and wide across England by working with all of our health and care sector partners in different parts of the country. And I'm here talking on behalf of all 15, and my role is directly involved with coordinating the delivery of 2 elements of our national work. Next slide, please. So we are both local and national organisations. That's the key message here. We do a lot of work in terms of capacity and capability building in the areas that we serve, all with the ultimate aim of trying to support the spread of both local and importing national innovation so that we're creating those cultural conditions for innovation to thrive. And then nationally, every year or 2 years, we work on some agreed national programme priorities. I mentioned the lipids programme earlier, and the Medtech funding mandate is another example of one of those programmes where all 15 HSNs support delivery in their regions. Next slide, please. Just wanted to put this up on screen to give those of you that maybe are coming to this new some context for this innovation and medical technology world that the HSN Network and our colleagues at NHS England and NHS Improvements Innovation Research and Life Sciences team occupy. So some of you might be familiar with this key policy document, the Accelerated Access Review, that was published 5.5 years ago now, I think, which concluded that several steps were needed to accelerate NHS patient access to new innovations, medicines, technologies, anything really. And through that review was born the Accelerated Access Collaborative, which forms part of the NHS England and Improvement Innovation Research and Life Sciences team, and a strengthened role for the HSN networks in supporting that scaling of innovations. And the Medtech funding mandate policy stroke programme is supported by both of us. So we work together across NHS England and Improvement and the HSN network to accelerate more equitable patient access to the technologies that are on the policy. And we've been doing that for just coming up for a year now. Next slide, please. So a little bit more information on the policy itself, and I'll probably turn your attention mainly to the right-hand side of this slide, actually, which gives you a flavour of the technologies that will be on the policy from the 1st of April this year. So the top four includes Heartflow, which is one of our existing 4 technologies, and then the bottom 7 are new to the policy. They'll all go live on the 1st of April. So now, as you can see, if you're reading those sentences, there's quite a breadth to this. We work in all facets of medical technology across different clinical pathways, all with the ultimate aim of trying to support the uptake of these nice recommended technologies so that we've got that equity and access embedded across England. That's our overall aim. And Heartflow we've been working with for a few years now, actually. It was previously on a centrally funded policy called the Innovation and Technology Payment. So the HSN network has got and built lots of experience in Heartflow, and colleagues at West Midlands HSN have been the sort of expert leads for that over the last few years. Next slide, please. So in terms of what we do for the technologies that we support, and of course this applies to Heartflow as well as some of the other technologies that are on the policy, we talk about these kind of 5 stages quite a lot in the HSN network. So we do a lot of work in our regions to understand context, so quantify and qualify current levels of uptake, who are the people that we need to be speaking to, what do the pathways look like, where are the opportunities for alignment or improvement with existing work. We then raise awareness around the policy, which is a key activity. This is quite new still, the Medtech funding mandate. We are finding that commissioners and providers across our newly forming ICS systems are still getting their head around many elements of it, including the monetary flow, how it all works together. Once we've got some buy-in and people want to implement one of the technologies that are on the policy, we can support them to do that. We act as an honest broker with the suppliers, which avoids NHS colleagues having to get too immersed in sort of commercial type conversations, but instead we can act as a bit of a buffer, share some of the resources that the suppliers produce, as well as any other resources that colleagues at NICE and elsewhere produce to try and support implementation. 4 and 5 are all in the kind of learning and sharing domain. And take them with all key stakeholders, and then we'll try and bring in knowledge, best practice implementation from other parts of the country to try and overcome some of those barriers by learning from the lessons that other stakeholders have learned from, and Heartflow is no exception to that. I know you're going to be hearing a little bit more about the technology shortly. I will stop there. Thank you.
Excellent. Thanks very much, Stuart. I think that's a lot. Thank you very much, but some exciting developments. So we'll move on to Dr. Timothy Fairbairn now, who's actually going to talk to us about how Heartflow actually works and who qualifies to get access to this amazing technology. Tim.
So thank you very much. So I'm going to take this from really 2 aspects. First of all, the patients, and probably most importantly, and then secondly, the doctors. I'll try to explain a little bit about how it works, but I'm not a physicist, so therefore we might have to leave some of the questions to Gina later on. But next slide, please. So essentially, if you present with symptoms which might be that of sort of angina, so a discomfort in the chest, which is related to a shortage of blood supply to the heart, then the doctor really has a few options in terms of what to do. The first thing is that they could do no tests at all and just start your own medications, and that often is appropriate. But more often than not, in discussion with the patient, the doctor will decide to get a test done. That's really to try to identify whether the symptoms that the patient's getting are that of angina, so related to their narrowing of the heart blood vessels or coronary artery disease. And the difficulty with it is that we used to think we were very good at it. You know, you'd see a doctor, you'd tell us, we would diagnose you, we'd get it right all of the time, and we'd manage you appropriately. But we understand more and more that, unfortunately, you know, we can't get it right all of the time. Every patient's symptoms are the same, and we understand this particularly in relation to, for example, women have of maybe less typical chest pain, you know, with the belt going around the chest, and maybe more symptoms such as breathlessness, which are angina. So we don't get it right all of the time as doctors, and therefore we do often need a bit of help. And in 2017 or 2016, actually, it was, NICE decided that they felt if we were going to get a test, for the majority of patients, probably the right test would be to get this CT scan. This is whereby we give a dye to the patient, take some pictures of the heart blood vessels using a CT scan and the dyes in the blood vessels. And this is a really good test, because if we want to ask the question, well, do you have any heart disease? So do you have any coronary artery disease or hardening of the heart blood vessels? We can see that. So we can see that here on the left-hand side of the picture. We've got a patient whereby there's a little bit of brightness in the middle of the blood vessel. And that's essentially coronary artery disease. That's a narrowing of the heart blood vessel. So we can see it. But the next question is, well, okay, if you have the disease, is it causing your symptoms? And in the past, what we probably do is go ahead and try and identify a shortage of blood supply. And the CT scan, as well as the invasive coronary angiogram, so looking at just what we call the sort of the tubes themselves, is great for detecting the disease, but it doesn't tell you about whether or not that blood is limited, and therefore it doesn't tell you whether it's actually causing the patient's symptoms. So we might, in that instance, want to get a functional test, which is the group on the right-hand side. So the variety of different sort of colourful pictures. Essentially, whichever one of these tests we did, we were looking for this shortage of blood supply. But we did have this one test that could do both. So look at the tubes themselves, look for the disease, but also if there's a limitation in the blood flow. And that's where this FFRCT from Heartflow comes in. So that in the middle, it's the pretty picture of these 3 heart blood vessels with the different colours showing the limitation of blood flow going down the blood vessel. So normal essentially is blue or green, and you can see in the blood vessel which is coming down the front, so right in front of you, you can see that it graduates and turns red, and red essentially is bad. That means that the blood flow has been limited going down that heart vessel. So what this can do is it can help us not only identify so we have the disease that we've seen on the CT scan, but it can help us understand as to whether or not that disease that we're seeing is actually causing the patient's symptoms. And that's important because it will help us decide what the appropriate management is for this patient. Can we move on to the next slide, please? So getting the diagnosis right is very, very important in terms of helping us try to understand what we should be doing and recommendations with that patient. And, what is important is that, first of all, it's a robust system, that it's accurate and it's reliable, but also that it's quite a straightforward process to be able to do. And I know Gina's going to touch on this a little bit later on, so I'll briefly mention it. But essentially, from a doctor's perspective, we've acquired the pictures of the CT scan and the heart blood. So we can see that there's some disease. And maybe in about a third of patients, we can't see any disease at all, which is great. We can reassure the patient. They can go home and they don't need any medication. And in about another third of patients, we might see some disease, but we know that it's not any problems because we can see it's only very, very mild. But in the last third of patients, unfortunately, they've got disease. It might be significant, and we need to answer that question. And what we would do now, so whilst you can go and get another test, what we can do is we can simply do one click, send off the pictures that we've taken. So the patient doesn't need another test. They've already had that CT scan. We just send it off. It goes off to Heartflow, and within 4 hours, we get an answer back with the model that I've just shown you with the vessels modeled using sort of 3D computational analysis and looking at that blood flow down the blood vessel. And that can help us understand as to whether or not the blood flow is limited. And that comes straight back to our computer systems, and we can integrate that into the patient's care record and into the report. So we can give a much more accurate answer as to whether or not that disease that we're seeing is causing the patient's symptoms. Next slide. So this is what I call sort of my typical atypical case. So the majority of patients that we see, as I said, do not have this, what we would call typical symptoms of chest pain. You know, you used to see them, a middle-aged white male with a belt around his chest, but we know that that's not the majority of the patients that we see. So this would be a lady who's in her 60s, who has what we call this atypical angina, so maybe breathlessness. Okay. Now, on the left-hand side, what we used to do is we used to estimate what the likelihood of them having narrowing of the heart blood vessels is. So in this instance, this lady we would say would have an intermediate likelihood of having heart blood vessel disease. So we go on and do a CT scan. She has calcium, so that's the sort of the highlighted picture in the middle with the different colors, the yellow, blue, and green. So we can see that she has coronary disease. And we go on and give the dye, and then we're looking at to see as to exactly how bad that disease is, and that's the pictures on the right hand side. So you can see a 3D model of the heart on the bottom right hand side and the blood vessels of the heart. And when we were analysing this, see that this lady does have disease, and that it's in what we would call the moderate range. So it's where we can't be certain whether or not it's causing the patient's symptoms. Next slide, please. So here is a sort of a close-up of the patient's blood vessels. So this blood vessel on the left-hand side, where you can see a bit of bright and white and disease, that's the narrowing of the heart blood vessel. So as I said, I can't be absolutely certain as to whether or not this is causing the patient's symptoms. So in the past, what we might have to do is send this patient off for another test, and that could be, you know, a minimum of 6 weeks wait for us to get that test result back, because, you know, we have to wait for the waiting times. But nowadays, what we can do is, if you just press next slide, please, we can send it off within 4 hours. I get this result back, and it's a nice blue color with all the numbers suggesting that there is no significant limitation to the blood flow. And if you just go to the next bit, then that means straight away within 4 hours, I can reassure this patient that they don't need any further investigations. They don't need to be sent for any invasive tests, and they can be reassured and place some medications. So this patient's journey from their perspective is a lot shorter than it would have been otherwise. And we can reassure them with greater accuracy and confidence that they're getting the right treatment. So overall, this is, I think, a really, really useful test, not just for the doctor because of the accuracy and the ease for which we can request it, but particularly for the patient, because essentially this patient is having a very accurate test which provides them with information which allows us to manage them in a more appropriate way. And that's done in a very timely fashion as well. Of course, it can identify patients who maybe need to go on and have further investigations or treatment in terms of if there is a limitation to the blood flow. So it can help us in either direction as to decide what the right thing to do is for the patient. So thanks for your attention. I'll hand over to, I think it's Kevin now.
Can I just, before we move on, and thank you very much, Tim, that's really, really interesting. Any questions that you have, please can I remind you to put them into the Q&A, and then we can address them at the end. So thank you very much. I'm sure this is such an interesting subject. So to move on, if we can, thank you very much. So I'd now like to introduce Claire Clues, who's director from the Lived Experience Network. So Claire, if you'd like to share with us, please.
Yes, I just wanted to explain really what the Lived Experience Network is all about. And as you can see on the slide, we advocate for the value that creative and cultural engagement brings to health and well-being in all of life stages for everyone. And also, we too are an organisation that ensures that the voice of the lens is central to the development of policy and legislation. We were actually born, as it were, out of the All Parliamentary Party Working Group, which Lord Howarth chairs. And we also have a number of regional champions who have had health problems or have ongoing health conditions that they have to live with. And through their own experience, of using creative arts or interest in culture, how that either helps them through a recovery phase after a serious health incident, or generally improves their overall health and well-being, even if they don't actually have a diagnosed health. I think it can be quite a preventative as well, particularly we've seen that in mental health as well. It's really, really helpful in that. And we empower people to share their stories about their own experience of creative and cultural engagement for health and well-being, and we build a compelling evidence base, which we've worked across a number of projects. We work in partnership with the Culture for Health and Wellbeing Alliance. Their website is there at the bottom. They kindly host our information as well. So if you want to find out more about the Lens and what we do, and more about the Culture, Health and Wellbeing organisation, that's the website to go to. What I can say is that we are really, really broad. We are across the country, and it's all wellbeing and areas of health and social care, as well as in the criminal justice system. We've seen some projects really work very well with offenders who are addicts and going through rehabilitation once they've come out of prison. We've seen a massive reduction in reoffending, and also just in the general wider community context. So that's really what I'm here to say.
Excellent. Thank you very much, Claire.
No
Much
problem.
appreciated. And so Kevin Frisbee is a Heart UK ambassador, but most importantly, he has an experience that thankfully is happy to share with everybody, but it's an unfortunate experience. Kevin.
Thank you, Jules. Yeah, my journey began, well, I'm ex-Air Force, so my journey began in 2006 when I had a regular or a routine blood test, and I was told I had high cholesterol. So I was put onto statins and thought nothing more about it until about 10 years later. I was suffering from aches and pains, headaches, tummy aches, and I saw my GP and I explained the situation. I had been through a whole range of statins, tried all of them, and in the end the GP did a risk assessment on me and said, you're low risk, you keep yourself fit and healthy, you do lots of exercise, you don't smoke, you don't drink, we'll take you off the statins. A year later, I had just been for a 10-mile run. I did my runs every other day, I did weights in between, and August 17th 2017 I had been for lunch with my wife and her father. I got home, I had a pain in my chest. I kind of thought it was indigestion, but it turned out not to be. The East Midlands Ambulance Service rushed around. They confirmed it was a heart attack. They whisked me off to Castle Hill, and I had an angioplasty, I had a stent put in, and they turned to me and said that was the biggest heart attack they'd ever seen, and they were concerned that I wouldn't make it. Grateful that I did, of course, thanks to the expertise of the doctors and the surgeons there. I'm not overweight. I had no symptoms before my heart attack. I looked after myself. I ate healthily. I didn't know anything about FH. I didn't know it was a family history thing. I didn't know my dad had high cholesterol. I didn't know my sister had high cholesterol. It ran in the family. I went on to have rehab at Princess Diana's Hospital in Grimsby. They provided an excellent service. The cardiologist there was fantastic, and I'm happy to say a year later, I was discharged from their care. Luckily, I dodged a bullet. I had no scarring. I do not have any coronary disease, and all I can say really is if I had known about, or if it had been available at the time, Heartflow, I think it would have made a massive difference to my heart attack. It probably wouldn't have happened. That's my experience.
Thank you very much. Do you think your friend would be happy with you also sharing an experience that they're going through?
Yes, I can share that. I mean, obviously, he's anonymous. I won't say his name. My friend, who's also still in the Air Force, and he is a medic in the Air Force, he had a heart attack last year. He had 3 stents put in, and unfortunately, one of them failed later on, 6 months or so later, which led to another heart attack. And I guess the concern is he doesn't know how his arteries are performing. He's taking medication, of course, but now, day in, day out, he gets a pain in his chest, which could be caused by any number of different reasons. But his first thought is, here goes another heart attack. And I think, you know, Heartflow would really reassure him that that's not the case. It could be anything, it could be indigestion, could be absolutely anything that's causing that pain. He's on the proper medications, so the chances are pretty good. I'm 4 and a bit years into my journey, so I can rationalize. He's still just over a year into his journey, and he feels anxious about what he's going through. So that's his experience. I'm going to direct him to this webinar later on so he can watch it when it's on the site. Hopefully that'll give him some support and guidance.
Thank you very much. Much appreciated, Kevin. So we'll move on to talk to Gina McDonald-Main. She set the company up. So Gina, why don't you share with us why you set the company up and where you're at today?
Thank you. See, I'm Gina McDonald-Main. I'm the VP of Government Affairs for Heartflow. I actually didn't set the company up, but I can give you a bit of information on who did. So first of all, why did we develop Heartflow? So this was developed to help non-invasively in the diagnosis of coronary artery disease. And Dr. Christopher Zarins, who was a vascular surgeon, and Dr. Charlie Taylor, who was an engineer, they developed a way by taking an invasive test called fractional flow reserve and replicating it via cardiac CT images and computerized fluid dynamics. And one of the key benefits is in the time patients receive a diagnosis and the fact they only require one test and one visit to the hospital in most cases. So as you can see from this slide, the current pathway, a patient would be seen in clinic, they would be sent for a coronary cardiac CT. The results would then go back to the cardiologist. The patient would then go back to the hospital. And as Tim Fairbairn has said, the doctor would need more information. So that patient would be then referred to another test. Now that could take 16 to 18 weeks, sometimes longer, depending on the patient waiting times in the hospitals. They would then obviously receive a diagnosis, and that could take up to 31 weeks. And this really does depend currently on waiting times in each individual hospitals. With the Heartflow pathway, a patient would be seen in clinic. They would receive a cardiac CT scan. And at the time of that scan, the doctors would look at it. And if there was any narrowing, they would then send that direct to Heartflow at the same time. Heartflow would then review the scan, and we guarantee 24 hours. The mean time at the moment is 4 hours. We would then send that report back, and then the doctor could then actually report the scan and send the results to the cardiologist on what treatment that patient requires. And that's around 7 weeks, so it's a lot better for patients. So what are we hoping to achieve in the future? Our future goal is to enhance the patient experience by helping direct patients to the most appropriate care, to reduce the amount of invasive angiograms and provide patients with a better experience. And finally, to reduce the cost to the NHS. Long term, next slide please, we want to be able to provide a complete picture of coronary artery disease. So these are some of the tools we're currently developing. There's Heartflow Planner. This is an interactive tool for cardiologists to help them plan what treatments patients need in the cath lab. We have our deep learning. So this is continually looking at our ways to improve our AL algorithm with intuitive learning. Our workflow integration is putting the Heartflow analysis into the elective heart patients' records. Our plaque work is identifying and characteristics of the plaque in the arteries to help with the treatment planning. And new measures, it's developing tools to look at the percentage of the myocardium affected and myocardium at risk. Thank you.
Fantastic. Thank you, Gina, for sharing that. And sorry, I got us slightly ahead of myself there, saying you set the company up, so apologies with that. But certainly developing the product will benefit many, many, many patients, as we can see. So I'd like to move on to Lisa Beaumont, who's now going to talk to us about social listenings and the findings that she has.
Thanks, Jules. Yes, hello, my name's Lisa Beaumont. I'm a fully qualified marketing professional. I switched from employment to being a freelance marketing consultant when I survived a brain hemorrhage in 2011. So as a result of that, I spent over a year in NHS hospitals. So I've got a huge amount of experience, patient experience, that I can bring to everything I do, because anything I do now is filtered by the fact that through the lens of my survival story that I live each day and my ongoing rehabilitation. And when I switched to become a freelance marketing consultant, I decided to look at what was it that I could do better now that I was actually living. I remain at home because I remain left side paralyzed, so I have limited movement. So I'm not running around doing things all day like most people, or like I used to be. So instead, I decided to find what was the opportunity in me being at home. And I realized that, in fact, social media has become a real lifeline to people who live with reduced mobility. And when you are at home, you have the time to actually read other things. So I gradually realized that by carefully reading social media feeds across all the different platforms, Facebook, Twitter, Instagram, LinkedIn, and so on, for each project that I work on, you can glean an enormous amount of information from the posts and the information that's shared online. And you can find out what people think about a product and what questions they've got and what language they use to talk about it in. And so I developed a product which is, I'm the only person who does this. I call it active social listening, because it's where I listen to what people are saying about a topic online and I actively engage with the person who's posted. So, I mean, mainly on a day-to-day basis, I do it for small businesses and sole traders, and where I see people who are saying, can anybody give a recommendation for a certain type of product? And then I can jump in and give information. So if I saw anything where anybody was saying they had concerns about heart issues, I'd be able to direct them towards Heart UK or Heartflow as relevant. So where one of the things I've discovered whilst working so much on the social platforms is that it's unfortunate that social media gets such a bad press generally, because in fact it's a hugely powerful source of information where you can get testimony directly from patients and individuals. And if you actually start mining it as a source, you can get that direct information from the voices themselves and really hear what people think and feel about something. So for this particular project, I was looking into, I was reviewing the online content for Heartflow and for the charity Heart UK, and I was looking for patient experiences of Heartflow. So what I found overall was that there's a very strong online footprint for Heartflow. I mean, and Heart UK is very active online as well. As you heard earlier, they've got their ambassadors who are working hard to drive awareness all the time. Yeah, and there's a lot of the online presence for Heartflow is driven out of their American parent company, Heartflow Inc. who have an enormous number of followers on all the different platforms. But for example, on LinkedIn, they have 1.3 thousand followers, and they use particular hashtags such as restless, stressless. Although I discovered with the hashtags related to this project that there are some, that's an area where actually social listening could really assist, because there's a certain amount of blurring between what's considered a term that might be associated with cardiology versus terms which individuals and patients just associate with matters of the heart and well-being generally. So a hashtag like stress less is also used greatly by a wide range of well-being practitioners, people who are promoting mindfulness and green tea and so on. So it is quite, you do have to be quite careful when you try and choose terms that you want to hone in on for any project, that you actually get one which is going to be distinct to your project, unless you want to grow your reach. I mean, it's one of the things that I did notice was that because Heartflow Inc. have been using stress less, it means that they've connected a lot with general well-being practitioners beyond the immediate cardiology community, which if that was part of their intention, then that's a good thing that they've done that. So next slide, please. So in terms of actually finding user experience, it was difficult to find patients who had actually been prepared to share their story about Heartflow online. The main story that I found is one that's been shared from the Heartflow Inc. account on Twitter about a patient called Mike Gartman, and that's available for everybody to read his story about how Heartflow has helped him. And on Instagram, there was, again, this blurring between the terms stress less and Heartflow, that Heartflow on Instagram is primarily associated with anything to do with matters of the heart and not anything to do particularly with the product that we're talking about today. So I have to say, Instagram wasn't a particularly useful source for Heartflow today. But it shows that there's so much coverage out there that if you want to take advantage of it and use it for your own purposes, it's a very powerful platform. Thank you. Next slide, please. So finally, in terms of my recommendations, I would say that if Heartflow is keen to collect more patient stories, it would be a good idea to encourage patients to share their first person testimony via different platforms. And that it's important that you bear in mind this confusion about the terminology, that it's worth spending time really understanding the language that's used. If you were to set up if you were to promote Heartflow UK and Britain, that would require a very different approach from the American terms. It would be useful to spend time examining how do patients refer to heart matters in the UK and then latch onto those terms. Thank you.
Thank you, Lisa. Thank you so much.
Thank you.
That's really, really interesting. So thank you for that feedback. I think that's very useful, and social media is such an important platform these days, as we know. So moving on to questions. So I am going to take them from the top, actually. So Tim, can I ask you to help with this? So 63-year-old female, calcium score of 550. I mean, I have to say, it is very difficult to deal with individual cases in such circumstances as this. But this is a positive, really great message. It's not specifically about somebody asking about their individual case. She was Carol was saying how her scans were sent to Heartflow about 2 years ago, and it was very reassuring to know there was no narrowed vessels.
Just like the case I showed, it could have been Carol. I don't know whether it was. But...
and yeah, I mean, that's absolutely incredible, isn't it? So is Heartflow available in Wales? Gina?
So currently there's only 2 hospitals, a private hospital and the NHS hospital, Royal Glamorgan Hospital, that have got Heartflow implemented. But actually last week I am working with some other hospitals on business plans to try and get some funding for Heartflow. So hopefully very soon we'll have Heartflow in a lot more hospitals in Wales.
That's great. That's great. And actually, let's just extend that question. What about England and Scotland and Northern Ireland?
So in Northern Ireland, yes, we are in Northern Ireland. We're currently in 4 hospitals and we're implementing with another 3. So that's all hospitals that provide a cardiac CT service where the government have funded that. And in Scotland, we're currently working with NHS Scotland to do a pilot with some of the sites. So we're in the Western Isles and we're working with Forth Valley hospitals and the Borders Hospital to implement Heartflow, and hopefully they'll be up and running very soon. And
in England, is it a
yep, so in England, yep, it's a national programme. We started obviously with the ITP. We're in over 80 hospitals at the moment and we're currently implementing another 20. So yes, it's yeah, widely available in England.
Fantastic. So that I can already hear that on the helpline. That would be a question. Where can I go and how can I get it? So that's good to know. And it's good to know that all nations are actually following. So could Heartflow have a role in providing ongoing monitoring of heart conditions following heart operations or a stent insertion, rather than wait until there's a further painful or dangerous symptoms? Tim, can I come to you, please?
So the short answer to that is no. You know, it's principally used as a diagnostic test to in patients who say who don't have already heart disease. So if you've had a heart bypass operation, I think the key one whereby really at the moment we don't send those kind of patients off for analysis with the Heartflow model. You can send patients who've got stents in and send off for the analysis of their non-stent blood vessels. So you can look at those patients as well. But again, it's really driven by symptoms. You know, symptoms are still very important. The key thing, I think the key message that I would say is, look, if you know you have coronary disease, then it's important that you're on medication for that. And that is the most important thing. You know, in terms of then trying to decide whether or not you need anything further doing, if you're getting symptoms, then I think this test is extremely useful, as we've discussed. But the key bit really, you know, the first thing, as you pointed out at the head of the program, is first of all, everybody should know what the cholesterol is, and secondly, if you need anything doing to it, and you know, and statins are one of the best tablets around, really do make a difference. So that's the most important thing.
Fantastic. So I think you've answered the next question, that there isn't a screening for high risk asymptomatic patients generally.
No, so I mean, not specifically using the Heartflow sort of FFRCT model. There are debates about whether or not we should be using CT coronary angiography itself as a test to try to detect patients who might have coronary disease, who are maybe in this sort of, as I described earlier, this sort of in the middle risk group. So they're not very high risk, They're not very low risk, but they're in the middle. And should you, want to try and find out whether or not they have disease. And in America, they're certainly using CD in this group of populations to try to help the patient and physician decide whether or not the patient should go on medications, so go on statins. But we at the current time in the UK don't do that. And I think, again, I would just sort of like to emphasize to everybody that in actual fact, if you want to have a lower risk, really the key things are about lifestyle. And if you want an even further lower risk, then medications. So tests don't necessarily change that risk as such, but it might better inform you as to what exactly your risk individually is.
Interesting. And there's somebody who's got familial hypercholesterolemia, which is the inherited form of high cholesterol, and it's genetic, obviously. Janet is concerned about going on to an injection medication, and wondered whether she could actually use this as an examination ahead of her making that decision, really, whether it would help or not. Any comment on that, particularly around FH, Tim?
Yeah, so FH is a difficult one, because the way that we try and sort of have discussions with patients is understanding what their individual risk is. So if they haven't got symptoms, that is, if you've got symptoms, then as I've mentioned earlier, it's very rational to then go on, try to decide to get a test to try and figure out whether that's causing your symptoms, and you're automatically a bit higher risk than if you don't have symptoms. But if you don't have symptoms, then we often will use risk models in terms of trying to figure out what that patient's individual risk is, and they put in things like age, whether you're male or female, what your cholesterol is, etc. But of course, in certain groups, and FH is one of those, these risk models are completely useless, and in the very young and very old, again, they're not very helpful, which is why NICE moved away from them. So FH is, I think, a different ballpark, and I would just say what I really said before, which is called, if you want to have lower risk, then you should go on treatment. That's essentially what it means, particularly over a lifetime. The younger you are, your overall risk might not be that high, but your lifetime risk is obviously marked. I'm trying to move away from just doing this, what your risk is at a set time, but understand what your lifetime risk is. And I think that's much more important. Can a CT scan help understand if there is build-up in the coronary arteries? Yes, it can. And that could help maybe move your risk either way a little bit. And it might help you make a decision in terms of medication. But in your particular instance, or in the instance of familial hypercholesterolemia, my recommendation would be to go on treatment.
Thank you. So a question from Ralph. What's the added cost of using Heartflow on a CT angio?
Does Gina want to pick this one up?
Yeah.
Yeah, so the cost in the UK at the moment is £523 and 8 pence. So that is on top of the cardiac CT.
Okay, so not particularly considered it very high cost, so it's not what's holding back the implementation at all. I mean, it is accepted by NICE, so that is that's a given then, if NICE recommend.
Yeah, it does provide cost savings to NHS England.
So I have 2 questions for Tim from a radiologist, consultant radiologist. What are your selection criteria for which cases have data sent?
So we will look at the patient CT scan, and then we will look at certain features that we're trying to decide as to whether or not that's causing a limitation in the blood flow, and then we will decide whether or not that that sort of patient warrants a further additional test. For instance, getting a Heartflow test. So probably the most commonly one is the narrowing or degree narrowing of the tube of the pipe more than half, so greater than 50%. And we know that if the narrowing is more than half, then there's a good chance that there is a degree of limitation of blood flow. But we can look at a variety of other factors as well. The length of the narrowing. Where the narrowing is it high up in the blood vessel, or is it down on the blood vessel? Which blood vessel is it in? So there's a variety of different factors that we'll look at when trying to decide which patients will be required to go on and have a test. And as I said, it might be in a third of patients that will be thinking about it. Not all of those patients will be suitable to have a Heartflow test, but many of them will decide to send off and get the additional information because it can be helpful. And I can see that she's asked about this test in the graph. So you know, as I mentioned earlier, grafts at the moment, we don't send patients off who've had a previous bypass operation. And with regards to if a patient's had a previous stent, so maybe they've had a heart attack previously, or they've had angina and had a stent put into one of their blood vessels, you can request the test, but it's principally to question about what the blood limitation is in the other blood vessels rather than in the actual stented blood vessel itself. So, you know, so there's lots of patients that can have this test and it's very appropriate, but at the moment it's not for everybody.
Okay, thank you for that. And I think there's a statement here from somebody else who's been through Heartflow down in Cornwall in Truro. So that's good. Joseph is asking a question about better treatments for BPH. What I would suggest is we do have a helpline, so please do either write to the helpline at ask@heartuk.org.uk, or the telephone number is available if you wish to telephone, which you can find on the website. I was just actually going to see there's one attendee. We are at 6:01, but I just wanted to see if Sean Spark is still on the line and whether he would just like to mention his question. I'm just going to allow him to talk. I'll just click on that. And if Sean is still on the call, then I'm sure he can share his question. Sean. No, I think Sean has left the call. So that's all the questions that have come in, and thank you everybody for your interest this evening and your time. And as I said earlier, this recording will be available on the Heart UK website, and we will inform everybody on the Consumer e-news when that is live. And please don't forget the Heartflow website as well. Lots of information on there. Tomorrow you will be receiving an email to thank you for attending, but also to ask you to fill in a very short survey, just so that we can have the feedback from you all. I do hope that you've benefited from these talks this evening, and that just leaves me to say thank you so much to all our speakers this evening. They've all been absolutely amazing and really quite some inspiring stories too. So have a lovely evening, everybody, and thank you all very, very much.